So recall that GI imaging is a big section in nuclear medicine as you learn about nuclear medicine procedures. And this video is strictly going to focus on the hepatobiliary studies. This would be HIDA with CCK, biliary atresia, biliary leak, and the sphincter of Oddi study. These studies all assess the function of the biliary tract in different areas or different pathologies. It's the same radiopharmaceutical used for all studies, but the protocols for all these tests are very, very similar, with only some minor differences to see a specific pathology. To review the anatomy of the hepatobiliary tree, think of it very much like a tree, but it functions upside down. Within the liver, there's a series of ducts where bile is produced in the liver. They make their way into the bile ducts. They will converge in the common hepatic duct as it leaves the liver. And then the common hepatic duct is right here at the top as it leaves the liver, and that eventually turns into the common bile duct. Now, branching off of the common bile duct is the cystic duct. That's the one that leads to the gallbladder. So the gallbladder will empty through the cystic duct down into the common bile duct. And then you also have the pancreas here with several pancreatic ducts. That will converge on the pancreatic duct, and both of those combine right here at the ampulla vater. And then as they converge into one, you have the sphincter of Oddi that then opens up to empty all of those contents from the liver, the pancreas, and the gallbladder into the duodenum or duodenum, however you say it. But it empties that into the small intestine. Anywhere along that pathway, just like plumbing in your house or wherever, if at any time there's an obstruction in one of the ducts, then it backs everything up in front of that. So a blockage here in the common hepatic duct would cause everything to back up into the liver, and then the patient would have symptoms of liver disease, jaundice, things like that. In the cystic duct would mean that things cannot leave or enter into the gallbladder, and that would lead to acute cholecystitis. You can also have a blockage here in the main common bile duct that can cause distension and things like that in the common bile duct, and it will also cause everything to back up into the gallbladder and the liver, and that will lead to accumulation of bile that then makes that person sick. You also have the sphincter of Oddi here, and this can have dysfunction in it just like any other sphincter. It's a one-way door that empties all of the bile into the intestine, but it can get diseased over time, especially if somebody had chronic gallbladder disease and the gallbladder or the common bile duct was distended and had a lot of pressure on it. Then this can get a little bit hardened over time or get disease and dysfunction in it. Typically, that will happen months or years after somebody's gallbladder has been removed, that they'll develop sphincter of Oddi problems. So any blockage anywhere along that biliary tree can cause the patient significant pain. For hepatobiliary imaging, the acquisition parameters are pretty much the same for all variations of the study. They're all tech-based, same radiopharmaceutical, so 140 keV with a 20% window. Low energy all-purpose or high-resolution collimator. Patients will be positioned supine. The camera position is anterior. Now the liver is in the right upper quadrant of the body, but the images are anterior, so the liver will appear in the left upper quadrant of the field of view because that's the patient's right side. Right and left are be reversed because it's anterior image. Injection to imaging time is immediate. Acquisition is dynamic with additional views on the right lateral RAO and LAO. Matrix is 128 by 128. Time per view is 1 minute per frame. Additional views or time per view is about 300 seconds or 5 minutes per projection. When the imaging is done, to process it, you'll sum, frame, and label the images appropriately. The cine is helpful and can be reviewed by the radiologist. For the gallbladder ejection fraction on the post-syncolyte images, place the region of interest over the gallbladder. Be really careful that you include the gallbladder in the cystic duct, but not the common bile duct, the liver, or any of the bowel. And then you'll draw a background region of interest adjacent to the liver. You want to make sure you're not including any liver, bowel, anything like that in the background, and avoid any ductal activity. And then the gallbladder ejection fraction is calculated using the following formula. You'll do the net gallbladder max minus the net gallbladder minimum, and you'll divide that by the net gallbladder max. You'll multiply that by 100, and then a normal gallbladder ejection fraction is greater than 38%. It's a little bit of a gray area between 35 to 40%. Some protocols, some physicians may think it's just a little slow, but not quite abnormal yet until it gets to less than 35. So that will vary a little bit based on the physician who's reading the study, but typically if it's greater than 35 or 38%, then it's considered normal. This is an example of hepatobiliary imaging after giving CCK. The purple region of interest there is around the gallbladder, and it's saying that the gallbladder ejection fraction is about 71%. And you can see that it empties throughout the images. This is another one. This one is abnormal. These are the 60-minute images. You see at the beginning, you see gallbladder really bright, and you start to see that it's going into the bowel. But over the course of giving CCK, a little bit of it emptied into the bowel, but not much. With this study, the gallbladder ejection fraction was 9%. And so the diagnosis for this one would be chronic cholecystitis. And this is an example of common bile duct obstruction. This is a perfect example of why you would not necessarily give CCK right away, and why you really need to see everything. You actually see a shadow here where the gallbladder is supposed to be. But on the CT images, you actually see that there's a stone there blocking it with that arrow contrast and non-contrast pointing to it. And then on the images all the way out to 60 minutes, you still don't really see anything but the liver. This is an example of biliary atresia. Now remember, these are done in babies. This is a congenital blockage in the tubes or ducts that carry bile from the liver to the gallbladder. And so you see liver, and then you see bladder in these 24-hour images. In the 5 minutes per frame, you see that it never really leaves the liver. And it's not being taken up by the hepatocytes, but it's not being turned into bile or leaving the liver. So rapid tracer uptake by the hepatocytes should occur within several minutes. You'll start to see the hepatic ducts in the gallbladder by 15 to 30 minutes. You'll see the gallbladder concentrated in 45 to 60 minutes, and you'll start to see it going down the common bile duct into the small bowel. Failure to visualize the gallbladder after morphine on delayed images means it's acute cholecystitis. The rim sign, which is where you see the outline of where the gallbladder should be, but you don't actually see it. This is severe. This usually occurs with gangrenous gallbladder, and you see this with acute cholecystitis. Delayed visualization of the gallbladder can be a sign of chronic cholecystitis. So if you see the liver and the common bile duct in the bowel, but it takes a little bit longer for the gallbladder to show up, that's a sign that it could be chronic. Decreased gallbladder ejection fraction means that it's chronic cholecystitis. It could actually be also a calculus cholecystitis. Non-visualization of the small bowel or delayed biliary to bowel transit is a sign of common bile duct obstruction. And then the presence of bile outside of the normal biliary system when the person has just had their gallbladder removed is a bile leak. This is the last one showing you the rim sign. The rim sign is basically a shadow or a cold spot where the gallbladder should be. And this is a sign of acute cholecystitis. With the arrow there pointing to it. And that's it for HIDA imaging. I hope that that helped you guys understand the different studies there. The one thing that I didn't really mention was the sphincter of Oddi study. And that's basically just a regular HIDA scan on somebody who has already had their gallbladder removed. And it's more of a chronic issue with the sphincter of gallbladder as a long-term complication of gallbladder removal. And so that's it for hepatobiliary imaging. Thank you guys for watching, and let me know if you have any questions. I hope you enjoyed the video.